Okay, we'll start on chapter 27 for anemia now. I think I need to scroll down here. Okay, so once I said before, the biggest thing you're going to deal with is iron deficiency anemia. Okay, and then of course we can talk some about pernicious anemia. This is where you have your vitamin B12 deficiency, and that leads to your macrocytic normochromic anemia. These are the, I'm sure everybody's seen the CBC, and you've got your hemoglobin, your hematocrit, then you have your HCHC and your MCV and all this, and that's what that has to do with. And RDW, your red blood cells. So when that's high, that means something too. But pernicious anemia has to do with your B12 deficiency, okay? And that leads to your macrocytic normochromic anemia. All right, and this is in red for a reason, so you must need to know that. So pernicious anemia is treated with what? Vitamin B12. Okay, you can give those shots. You can give the orals. The orals don't help a whole lot, though. Okay, so you have your treatment goals. You want to increase the hemoglobin because that's what carries your oxygen through your blood. Okay. Now, this is where I want, anything in red is really what you need to know for sure. So, iron deficiency anemia, really common in infants and especially breastfed infants. So, replacement in breastfed infants, this is replacement, is 1 milligram per kg per day. So, for preterm infants, it's 2 milligrams per kg per day for 12 months. At 15 months, the ratios are going to change a bit. It's going to be 6 milligrams per kg per day of elemental iron. So remember, everything for kids is based on kilogram by weight. Okay? In adults, the gold standard of treatment is ferrous sulfate, 325 milligrams, 3 times a day. And you have a lot of crabby people about that. They're not too happy. You do not want to, they do not want to be bothered with that. And it upsets people's stomach and it causes constipation. So they're never too happy with you, especially your elders. Okay. So when you have somebody who has iron deficiency anemia, you're going to want to monitor all these things. You need to check a retic count because once you've started the iron, your retic count should increase somewhat. But you're for sure going to check your hemoglobin, your hematocrit, your ferritin at 4 weeks, and then at 3 months and annually, and keep moving on with that. Unless you have something that's so severe that you think they're losing blood, you're going to be checking those CBCs much more often. You're going to be checking stools for occult blood. You're possibly even going to send them for colonoscopy and endoscopy. You're going to be watching for those renal functions. Okay. Constipation, they may need a stool softener, but you can also tell them to increase fluid and fiber to ward off that constipation. Okay, so folic acid. Here's all your risk groups that could be folic acid deficient, goat milk or powdered milk formulas, vegetarians and vegans. Pregnancy increases the requirement, but we also know that if we give folic acid, that cuts down on those neurotube defects. That's a whole other story though. But as far as folic acid deficiency, patients with sprue, I don't know if you've heard of celiac sprue, that's a form of a malabsorption. Crohn's disease, Giardia infections, and short bowel syndrome require oral folic acid 1 to 2 milligrams daily. So back to the pregnant women again. Usually we tell them to take a full milligram daily in pregnancy, and you want to tell your patients if they come in, you just have someone who's thinking about getting pregnant, you want to have them start that folic acid. The other thing too is for your exam though, the number, and in the book I believe it's 800 mics per day of folic acid. Once again, real world and test. For this test you're going to tell them 800 mics, but in real life just tell them a whole milligram of folic. Okay, let's click down. Okay, so here we go again. Women of childbearing age and pregnant women should consume 800 mics a day. Okay? And if you have somebody that's actually folic acid deficient and it's causing anemia, you're going to follow a hemoglobin and hematocrit at 1 week, and then at 8 weeks. You're going to always have those baselines. And you're pernicious. It's caused by inadequate vitamin B12. A lot of times in the older people, the gut stops working, or if you've had any kind of gastric bypass, if you've had any kind of gastric cancers, they have a hard time absorbing that vitamin B12. So those, you can tell them to eat the foods in high in B12, and that's not going to work, is it, with real true pernicious anemia. So these are the people that need the IM dosages of vitamin B12. There's some merit to the sublinguals as well, but mostly just go ahead right for the IM vitamin B12. There are people that require them actually every once a week, twice a week, but usually monthly is the general dosage. Okay. Okay, so this gets a little confusing, and this is mostly just for your exam. So the therapy with the B12, there's oral IM, intranasal, and once I just told you sublingual. That's not on here, but that's a pretty popular one. So treatment of vitamin B12 deficiency, they actually have a nutritional deficit. So you need 1,000 mics a day of B12 until your B12 is normal, okay? Pernicious, it's the vitamin B12 therapy. This is the IM dose. The other one is the oral. The IM dose is 1,000 mics IM daily for a week, followed by 1,000 mics IM weekly for a month. These are people that are really having a really hard time. Now, just recently, actually just today, I saw the bottom number for a B12 level is 200, and I had somebody that was at 220, and I actually put her on an IM dose just times 2, once 2 weeks apart, and then monthly after that. This is somebody who's status post CVA, super tired, so maybe it'll help her out a little bit, and it may not. We'll have to see. Okay, once again, pay close attention to the things in red, really research them as well, and match them up with the book and the PowerPoints. You want to watch a retic count. Why is that? Retic is the sign that we're making new red blood cells. Hemoglobin and hematocrit, your iron, your folic acid, and your B12 levels prior to treatment, and then 5 to 7 days after therapy started, and then frequently, okay? You have to watch potassium levels with B12 therapy. Increases your potassium. You can become hyperkalemic. All right. And let's see. And I think we're good. Anemia of chronic diseases. This is what I was telling you about before. This is your renal failures. You have a lot of patients with renal failure. These are your patients that are your diabetics, your COPDers, your patients with your CHF, the ones that you're going to have in your practice that are so difficult to manage. You have CHF exacerbation, now you've wiped out their kidneys. You wipe out their kidneys, now they have no hemoglobin. So it's just a vicious circle. Okay, so that's when those Procrit shots come in handy, the Epigen. All right, and this is more about Epigen again. Some of these slides are over and over redundant. I just want to make sure that we are okay before the beginning. So remember, before beginning the IM B12 therapy, you want to make sure that you're checking your retic count, your hemoglobin, your hematocrit, your iron, and your B12 level. And you want to make sure that you're always monitoring your potassium level when you have somebody who's on IM vitamin B12. And the overall goal is to give them some more energy, and hopefully that their anemia will resolve.